Assalamu alaikum. Auzubillahi minash-shaytanir-rajim. Bismillahir-rahmanir-rahim. It's a series of lecture regarding gynecology and obstetric. It's a 10-page attached stretch. Now I would like to discuss about this important topic, which is lactational mastitis. If we look for the pathogenesis of this disease, first of all, find out the exact cause, the infection. Skin flora like Staph aureus enter the duct through the nipple and multiplies in stagnant milk. It multiplies in the stagnant milk. Staph aureus enters the duct through the nipple and multiplies in stagnant milk. There may be history of mastitis. There may be history of mastitis. Engorgement and inadequate milk drainage. Engorgement and inadequate milk drainage due to sudden increase in sleep duration, replacing nursing with formula or pumped breast milk, weaning, pressure on the duct due to tight bra or clothing, prone sleeping, cracked or clogged nipple pore, and poor latch, high yield. Poor latch is high yield. Most of the new mother usually don't know how to breastfeed, so poor latch and thus causing this type of inflammation of the and thus causes inflammation of the breast, and it is called lactational mastitis. So history of mastitis, engorgement and inadequate milk drainage. Why due to a sudden increase in the sleep duration, replacing nursing with formula or pumped breast milk, weaning, pressure on the duct, tight bra or clothing, prone sleeping, cracked or clogged nipple pole latch. A clinical presentation: fever, firm, a red tender swollen quadrant of unilateral breast, and myalgia, chills and analgesia, frequent breastfeeding or pumping, and antibiotic. Okay, a common infection in breastfeeding women due to inadequate milk duct drainage from pumping breast milk or poor latch. Patients with lactational mastitis are diagnosed clinically and typically have flu-like symptoms, focal unilateral breast pain with surrounding erythema and induration, and axillary lymphadenopathy. So, flu-like symptoms, focal unilateral breast pain, and axillary lymphadenopathy. Lactational mastitis occur when bacteria from the infant's nasopharynx or from the maternal skin are transmitted through the nipple and multiply in stagnant milk. The most common pathogen is Staph aureus, and the treatment is empiric therapy against MRSA with either dicloxacillin or cephalexin. Treatment is empiric therapy against MRSA with either dicloxacillin and cephalexin. Women are at risk. Women with risk factor for methicillin resistant Staph aureus and recent antibiotic therapy incarceration are treated with clindamycin, trimethoprim, sulfamethoxazole, or vancomycin. In addition, to antibiotics and analgesic. In addition to antibiotic and analgesic, ibuprofen, antibiotic and analgesic patients should continue breastfeeding every 2 to 3 hours because direct feeding from bilateral breast drain milk duct. Continuous breastfeeding every 2 to 3 hours because direct feeding from the bilateral breast drains the milk duct. Now, breast abscess usually happen if maternal age is more than 30, first pregnancy, and tobacco. Maternal age more than 30, first pregnancy, and tobacco, fever, focal inflammation, and fluctuant tender mass. And what we have to do is to do breast ultrasound, and antibiotic and drainage should be done. Most patients with lactational mastitis respond quickly within 1 to 2 days to the antibiotic therapy. Some patients can retain infected stagnant milk typically due to incomplete emptying that can lead to focal collection of the purulent fluid. Breast abscess, because the abscess forms a walled off cavity, it is less susceptible to antibiotic penetration. Therefore, patient may have improvement of overlying skin erythema but no improvement in systemic symptoms, malaise, appetite with antibiotics. The diagnosis of the breast abscess can be made clinically, but an ultrasound is performed to differentiate severe mastitis from abscess in patients with tender breast nodularity but no palpable discrete fluctuant mass. Management is with abscess drainage, ultrasound guided needle aspiration or surgical incision and drainage. Continuous breastfeeding is recommended for milk drainage. Treatment is dicloxacillin and cephalosporin. Dicloxacillin and cephalexin have similar coverage for methicillin sensitive staph aureus. Breast engorgement commonly occurs 3 to 5 days after delivery when colostrum is replaced by milk, resulting in high milk production volume. Resulting in breast engorgement happen in 3 to 5 days after delivery. That's because at that time colostrum production happens. The engorgement is exerted by a physiological increase in interstitial edema. Physiological increase in interstitial edema from decreasing progesterone level after delivery. Engorgement decreasing progesterone level after delivery. Decreasing progesterone level after delivery. Engorgement may also occur during times when milk accumulation exceeds drainage. Breastfeeding, weaning. Patients with breast engorgement have bilateral breast fullness with diffuse tenderness and erythema. Cold compression, acetaminophen, NSAIDs may be used for symptom control. Patients should experience improvement as breastfeeding or regular pumping is established. Patients with lactational mastitis often have flu-like symptom, fever, myalgia, and unilateral breast pain with a focal area of erythema and tenderness. A galactosile and blocked duct are a common problem in breastfeeding women, but both typically present as palpable mass. Candida mastitis can be caused by spread from the infant oral flora. Patients typically have nipple pain that radiates across the breast with latching. However, the pain is described as sharp shooting and is usually out of proportion to the examination. In addition, it is typically unilateral and the affected breast often has flaky scaling over the nipple. Now, gynecomastia. What happens in gynecomastia? In gynecomastia, it happens in increased estrogen production or peripheral conversion. It may be androgen deficiency or it may be any sort of medication effect. Increase estrogen production or peripheral conversion. The causes are testicular adrenal or HCG secreting tumor, testicular adrenal or HCG secreting tumor, obesity, cirrhosis, thyrotoxicosis, and androgen use. Testicular adrenal or HCG secreting tumors are obesity, cirrhosis, thyrotoxicosis, and androgen use. And androgen deficiency, primary or secondary, male hypogonadism, hyperprolactinemia, and renal failure. Primary and secondary, male hypogonadism, hyperprolactinemia, and renal failure. And medication effect is decreased androgen production. Decreased androgen production is GnRH. Decreased androgen production is GnRH agonist and ketoconazole GnRH agonist and ketoconazole decreased peripheral conversion to dihydrotestosterone is 5-alpha reductase inhibitor and inhibition of androgen receptor is spironolactone and bicalutamide. Increased estrogen production or peripheral conversion is testicular adrenal or HCG secreting tumor, obesity, cirrhosis, testicular adrenal or HCG secreting tumor, obesity, cirrhosis, thyrotoxicosis, and androgen use. It may be androgen deficiency like primary or secondary male hypogonadism, hyperprolactinemia, and renal failure. And medication effect is decreased androgen production like GnRH agonist, ketoconazole, decreased peripheral conversion to dihydrotestosterone 5-alpha reductase inhibitor, inhibition of the androgen receptor, spironolactone bicalutamide. Gynecomastia may present with subareolar mass, firm subareolar mass. However, it is more typically bilateral versus unilateral, mobile versus fixed, and tender versus non-tender during its growth phase. Hypogonadism, testicular germ cell tumor. Pubertal gynecomastia, imbalance of the estrogen and androgen during mid-puberty. Tanner stress 3 to 4. Pubertal gynecomastia. A clinical feature is small, less than 4 centimeter, small, less than 4 centimeter, firm, unilateral or bilateral subareolar mass. Small, less than 4 centimeter, firm, unilateral or bilateral subareolar mass. Reassurance and observation resolves within a year. Reassurance and observation resolves within a year. Small, less than 4 centimeter, firm, unilateral or bilateral subareolar mass. It is the imbalance of the estrogen and androgen during mid-puberty. It is most commonly occurs in boys 12 to 14 during mid-puberty due to transiently increased testicular production of the estrogen compared with testosterone. Estrogen compared with testosterone and peripheral conversion of prohormone to estrogen and peripheral conversion of prohormone to estrogen. Thelarchy typically is the first sign of the puberty. Typically, the first sign of the puberty is normal in girls. Age more than 8 is characterized by firm, often tender breast bursts posterior to the nipple. Breast bursts can be unilateral in the early stages of puberty. Differential diagnosis of the adolescent gynecomastia. pubertal gynecomastia, Klinefelter syndrome, testicular tumor, adrenal tumor, and maybe pseudogynecomastia. Okay, in pubertal gynecomastia, in adolescent patient, there may be gynecomastia. There may be pubertal gynecomastia, physiological rise in estrogen, then the testosterone, and gradual onset 12 to 14 diagnosis 3 by 4, small to moderate, less than 4 centimeters, subareolar enlargement resolves spontaneously within a year in most patients, and Klinefelter syndrome, small form testes, low testo, high LH, and slowly progressive breast enlargement. Testicular tumor, age more than 15, rapid onset, it may be germ cell tumor, nerve cell calcifying certainly tumor with or without palpable mass, high estradiol, high beta hCG. An adrenal tumor, rapid onset, may be associated with hypogonadism and testicular atrophy, high estradiol, and dihydroepiandrosterone. Pseudogynecomastia is diffuse enlargement of the breast fat, no distinct margin of the glandular tissue, and obese habitus. Both physiologic and pathologic gynecomastia can be unilateral or bilateral, Pseudogynecomastia is characterized by chronic excessive deposition of fat in the breast without a distinct margin. Typically in patients with obesity, uh, there is pseudogynecomastia. In true gynecomastia, enlargement of the glandular breast tissue, but pseudogynecomastia, there is excessive deposition of the fat. The margin of the firm glandular tissue is often palpable and breast may be tender. In gynecomastia, breast may be tender. The diagnosis is based on clinical finding. Management includes weight loss, breast imaging, mammogram, ultrasound should be considered to exclude the malignancy in patients with eccentric, asymmetric, nodular breast funding. Imaging not required in case of pseudogynecomastia. Tamoxifen, selective estrogen receptor modulator, that is used to treat gynecomastia and is sometimes used to prevention of gynecomastia in patients receiving androgen therapy for prostate cancer. It is beneficial. It is not beneficial in pseudogynecomastia. Gynecomastia may be treated with tamoxifen, and it is used for prevention of gynecomastia in patient having anti-androgen therapy, flutamide, bicalutamide, these type of drug who are having for prostate cancer. For those patients you can give tamoxifen, but for pseudogynecomastia it is not that helpful. Then the benign breast disease, very, very, very high yield. Diagnosis is breast cyst, fibrocystic change, fibroadenoma, and fat necrosis. Breast cyst is solitary, well circumscribed mobile mass with or without tenderness. Solitary, well circumscribed mobile mass with or without tenderness. Fibrocystic changes, multiple diffuse nodule-cystic masses, cyclic premenstrual tenderness. Fibroadenoma is solitary, firm, well circumscribed, and mobile mass. Solitary, firm, well circumscribed, and mobile mass. Cyclical premenstrual tenderness. And the fat necrosis is post-trauma or surgery, firm, irregular mass, ecchymosis, skin or nipple retraction. Firm, irregular mass, ecchymosis, skin or nipple retraction. Fibrocystic changes of the breast is very common in premenopausal is a very common in premenopausal patient. Classic presentation in patient with cyclical breast pain, mastalgia and diffuse nodularity. Cyclical breast pain and diffuse nodularity. Nipple discharge is not typical, but if present in non-bloody physiologic. Fibrocystic changes are benign and common in women of reproductive age. The changes may develop from fluctuation in estrogen and progesterone during the menstrual cycle. Symptoms typically improve during or after menstruation. Patient can be offered NSAIDs, oral contraceptives, for symptomatic relief. Fat necrosis is a firm, irregularly shaped breast mass. Often possible with ecchymosis of the overlying skin and without nipple tissue and a history of local breast trauma or surgery. Findings of oil cysts on mammography. Findings of oil cysts. The benign condition is associated with breast surgery, a breast reduction or reconstruction, trauma, seatbelt injury. Fat necrosis can mimic breast cancer in its clinical or radiographic presentation because it commonly presents as fixed mass with the skin fixed mass with the skin and nipple retraction with a fixed mass with the skin or nipple retraction gives the appearance of calcification on mammography. Ultrasonography can demonstrate hypoechoic mass, which often correlates with the benign etiology. Biopsy is diagnostic and typically shows fat globule and foamy histiocytes. Biopsy is diagnostic and typically shows fat globule and foamy histiocytes. Despite benign biopsy, the entire breast mass is often excised due to concerning of the calcification or mammography and is fixed irregular on clinical examination. Whole mass is excised. Routine annual screening is sufficient at the risk of the breast cancer as the risk of the breast cancer is not increased. Axillary node dissection, radiation and mastectomy is not needed. Fibroadenoma is age less than 30, often sensitive. It is often sensitive to the estrogen. Age less than 30, often sensitive to the estrogen. Small, firm, well circumscribed mobile mass, usually in the upper outer quadrant of the located in the upper outer quadrant of the breast. In adolescent, a suspected fibroadenoma reassurance and re-examination of the next menstrual cycle may be appropriate. If the mass decreases in size and tenderness after the menstrual period, the patient can be reassured the probability of benign disease is very, very high. However, adults with palpable breast mass uh, require further evaluation with imaging because the history of physical examination alone can not reliably diagnose or exclude the cancer in population. Women aged less than 30 are initially evaluated with breast ultrasound due to increased density of the breast tissue. Solid or complex appearing masses on ultrasound may require additional imaging like mammography or image guided core biopsy to exclude the malignancy. Excisional biopsy lumpectomies are typically reserved for patients with abnormal core needle biopsy for symptomatic relief of large growing benign breast lesion. Phylloids tumor are rare form of breast tumor that in the early stage of growth share the similar characteristics with fibroadenoma. Unilateral isolated form well circumscribed mobile mass. However, for large tumor typically grow much larger, resulting in change in the shape, contour, and the skin of the affected breast. Mammary ductal tissue is validation of the blood vessel and present with unilateral isolated breast mass. However, these benign lesions are typically subareolar and are associated with nipple discharge and classically green, brown, sticky due to inflammation of the subareolar breast duct. Associated with findings include a nipple discharge, overlying erythema, and nipple inversion. Intraductal papilloma, a papillary tumor involving the breast duct, typically presents with bloody nipple discharge but not associated with breast pain. Unilateral bloody nipple discharge not associated with breast pain or lymphadenopathy, mammography with or without ultrasound, biopsy, or excision. Breast pain. How will we manage the breast pain? If there is management breast pain, cyclical, bilateral, diffuse. Cyclical, bilateral, or diffuse. If there is mass, imaging, no mass, observe. Non-cyclical, unilateral, focal. Mass, biopsy, referral to the breast surgeon. No mass, imaging, normal, observe, abnormal, biopsy. Cyclical, bilateral, and diffuse. Mass, imaging. Cyclical, bilateral, diffuse. Mastalgia.